Kia ora, anō rā. It's time for some more CNS pathology. Here we go. We're going to do degenerative brain diseases this time. And again, we're going to look at the curriculum, and these are the diseases that you absolutely must know about. These are our core conditions. So we're going to do these and maybe a bit more so that you're going to be good doctors. Okay. Again, you have in the past in ELM learned about these diseases. So in particular, Alzheimer's, Huntington's disease, CJD, and vascular dementia. We are not really going to talk about CJD and vascular dementia today very much, but we are going to introduce some other dementias. Here are some key ideas. So the first key idea is that dementias have characteristic presentations. So you can tell them apart clinically by the way they present. Sometimes there's a lot of overlap. And they have characteristic both macroscopic and microscopic changes in the brain. Not that they're usually biopsied for diagnosis. Never really. The third key idea that runs throughout the talk today is that abnormal proteins kill neurons. And even though they're not biopsied, you do need to understand the pathology to understand the treatments. Okay, let's go to what causes chronic confusion. So these are the most common causes. Just watch the spelling mistake. These are the most common causes of dementia. Okay. So here we go. Dementias have characteristic presentations and characteristic macroscopic changes in the brain. So we're going to use Alzheimer's disease first, as it's kind of the prototype dementia because it is the most common of the dementias. All right, so characteristic changes in the brain that across all dementias are that they have a decrease in brain volume, which is shown by a thinning of the cortex and expansion of the ventricles and widening of the sulci and narrowing of the gyri. So those are typical atrophic changes that we see. All right. So dementias have characteristic microscopic changes, and they're reflected by their abnormal proteins. So here we've got a couple of neurons. This one's got a Lewy body in it, and this one's got a Pick body in it. And these are abnormal accumulations of proteins, and these abnormal proteins kill the neurons, and the different accumulations have different appearances. They occur in different neurons, causing different symptoms, and they can be treated in different ways. Okay, so there are particular microscopic changes that you should know are linked with particular diseases. Okay, so this is me telling you, please memorize this list. Okay, so in Alzheimer's disease, we have neurofibrillary tangles, neuronal plaques, Pick bodies, that's easy, in Pick's disease. Both Parkinson's disease and Lewy body disease have Lewy bodies in them because they are part of a similar kind of a grouping of diseases that we will talk about. And then there's multi-infarct dementia, which has multiple foci of typical tiny infarcts, like liquefactive necrosis and gliosis. You learn quite a lot about Alzheimer's disease in year 3, learning that it has typical symptoms, that it's associated with a particular protein that increases the risk. So the apolipoprotein E4 or epsilon 4 is a relatively common gene in the population, and heterozygotes generally don't have a problem. But if someone is homozygous for the protein, has 2 copies, then they have a 50% chance of having Alzheimer's disease, often of earlier onset. It also means that 50% of them don't get Alzheimer's disease, so it's better thought of as a risk factor rather than the causative gene. It's an association. All right, so people get confused about what are neurofibrillary tangles and what are neuritic plaques. Okay, so we're going to go through this a couple of times in different ways to see if you get it, but tangles are associated with tau in the tail of the neuron, okay? The inside the neuron. Tangles, tau, tail of the neuron. Plaques are placed outside the neuron in the neuropill. So plaques are in the neuropill, right? And they're often called neuritic when they're associated with degenerating axons. But plaques are in the neuropill. That's the fluffy stuff in the brain that we see down the microscope. And tangles are in the tail, and they're associated with tau. Okay, so where does amyloid come into all this? So we know that in Alzheimer's disease, we have amyloid. So amyloid comes from the amyloid precursor protein. So the amyloid precursor protein is a transmembrane protein that is normally cleaved to give a soluble fragment that goes off and like disappears. But if it's cleaved in the wrong place, it forms an insoluble bit, okay, which then goes and forms amyloid, these clumps of what we call beta pleated sheets. It clumps together. They look like 2-minute noodles, right? The kind of wavy 2-minute noodles, okay. And it's a bit interactive, all right? So amyloid forms the center of the plaques in the neuropill. It also migrates to the vessels and infiltrates the vessels, making them thick and hard to get oxygen through. Yeah. And it can also promote tau to go into tau tangles. So it's a really interactive process, but the simple way to do it is to think amyloid plaques are in the neuropill and around the vessels, and tau tangles are in the tail of the neurons. Right. There's lots of different little places. It can be excised, cut through. And there are some forms that are much, much more toxic than others. So this can explain the differences between things like progression and symptoms in different people with Alzheimer's disease. So we know that this beta amyloid precursor protein is a transmembrane protein. So what does tau do? Tau binds and stabilizes microtubules. So microtubules are the little things that transport nutrients and other things down the tail of the neuron and back again, and it stabilizes them. Okay, so if tau has an abnormal change in it, it detaches from the microtubules and then sticks to other tau and forms these tangles. It also means that, of course, the microtubules don't work, and so that process together with the tau tangles can kill the neuron. What else goes wrong in Alzheimer's disease? Well, the brains need their waste clearing away, and often that's done by microglial cells. So microglial cells, remember, we learned about when we were learning about strokes, and they are the macrophages of the brain, okay? So you're having all this stuff appear, all this amyloid appear and debris, and it can be accelerated if the microglial cells malfunction. So as well as amyloid and tau forming the plaques in the neuropill and the tau in the tail, there's also a whole lot of inflammation going on because the microglial cells aren't clearing away waste. So Alzheimer's disease, as we learn more about it, it becomes quite complicated. Let's have a look at a few pictures. All right, so here we go. This is a neuritic plaque. They look different. Yep. So these are the alpha beta amyloid that we're seeing here, and it becomes a true neuritic plaque. when it gets this core of broken down dendrites and stuff in the middle. But this is all amyloid in the brain. This is all amyloid in the brain as well, surrounding the blood vessels, making them difficult to get oxygen through. And these are the neurofibrillary tangles in the tail, okay, which is tau. Okay. And of course, Alzheimer's disease. This is very typical. So Alzheimer's disease often begins in the hippocampus. It's the first thing to lose volume, and then it migrates through mainly the frontal and parietal lobes and temporal lobes, so the front part of the brain, giving rise to this marked brain atrophy. All right, so there's treatments now that can treat Alzheimer's disease, monoclonal antibody treatments that have a variety of slightly difficult names, all ending in well, that doesn't end in AB. AB generally means antibody, monoclonal antibody. So here we go. So this one prevents amyloid plaques in the brain from clumping. Good. Maybe those microglial cells will have a chance to clean it up. This one here, been shown to reduce amyloid plaques and tau proteins, and this one is similar. So mostly the work at the moment has been on reducing amyloid accumulation, which, as we know, has a complicated relationship with tau and inflammation. But people are also working on tau aggregation inhibitors and tau vaccines. Let's move on to frontotemporal dementia. What is frontotemporal dementia? It's a group of dementias. There are four main ones, but the most common one and most distinctive one is Pick's disease, also now known as behavioral variant frontotemporal dementia. And it changes people's behaviors. So changes in personality, behavior and judgment, impulsive acting, doing inappropriate things, problems planning and sequencing. It's important because while it's a long way behind Alzheimer's disease overall, it's really important in people who are younger. So 45 to 65 is when it mostly occurs. And while it's only 25% of the dementia over 65, it is a large proportion of dementia in young people. So people will come to some MCQs that demonstrate someone who has Pick's disease, but you know that they will inappropriately swear, for example. Okay, so I'm going to call it Pick's disease rather than behavioral variant frontotemporal dementia because it's easier to say. It's also a tau disease. But this time, the tau does something else. So rather than forming these flame-shaped clusters because it's associated with neurofibrils, instead we get Pick bodies. So this is immunohistochemistry. I mean, it forms these round blobs, right? And Pick bodies. They still kill the neurons. They kill the neurons here, particularly in the frontal lobe. So frontal lobe is, of course, where you get executive function and behavior control, and that's why people have abnormal behavior. Okay, that was Pick's disease. Now we're going to talk about Parkinson's disease, right? I'm sure you've heard of Parkinson's disease. You know it's a movement disorder that is derived from the abnormalities in the basal ganglia, in particularly the pigmented neurons of the substantia nigra. Okay, so this is normal. This is substantia nigra that's looking very pale. And that's because these pigmented neurons are dead. Why are they dead? Because they have aggregated proteins that form Lewy bodies. So synuclein is the protein that's aggregated. So they're often called synucleinopathies. Okay. So these are called Lewy bodies. Parkinson's disease can be associated with boxing. So somewhere in my mind, there's a boxer called Louis who has Parkinson's disease. That's how I remember it. Okay, so here we go. So here's a typical question. 75-year-old male dies of an unrelated cause, but he's been having difficulty taking care of himself at home. These are the typical symptoms of Parkinson's. He has shaking of the arms and legs, difficulty initiating movement. And so what are we going to find in his brain tissue? Well, of course, we are going to find Lewy bodies in the neurons of the substantia nigra. Okay, so is it A? No, this is Alzheimer's. Is it B? No, this is Pick's disease. Yes, it is C, Lewy bodies. And D, no, this is a very non-specific change that is seen in the dementias that affect the forward part of the brain. So widened ventricles and sulci would be seen in things like Alzheimer's disease and Pick's disease. Let's think about Lewy body dementia. Okay, so there's a group of diseases which are associated with Lewy bodies. One of them is Parkinson's disease, the movement disorder. But some people with Parkinson's disease can also get dementia. So there's a thing called Parkinson's disease dementia. Okay, they have Parkinson's disease and dementia. There is a dementia called dementia with Lewy bodies, which is different to that. They don't have Parkinsonian diseases, but they still have Lewy bodies. Okay. So true Parkinson's disease, the movement disorder, Parkinson's disease dementia, Parkinson's with dementia, and dementia with Lewy bodies all have Lewy bodies caused by accumulation of alpha-synuclein. The normal function of alpha-synuclein is that it modulates DNA repair processes. Okay, so here's a couple of MCQs. 66-year-old man has undergone personality change. Oh, you should already be thinking, frontal lobe, okay? Becoming irritable, compulsive, argumentative. He has diminished higher cognitive function, and he has marked asymmetrical atrophy in the frontal and temporal lobes. So what are we thinking this is? We are thinking that this is probably a frontotemporal dementia. So what gives rise to frontotemporal dementia? Well, Pick's disease, for example, we know has got Pick bodies, and they're caused by tau protein. So that's the kind of reasoning that you need to be able to go through. All right, which one of these options? So yes, it's going to be E. It's going to be tau protein aggregates in the neurons. It's not going to be this, because alpha-synuclein is associated with Lewy bodies, and Lewy body dementia and Parkinson's dementia does not sound like that. Loss of striatal pigmented neurons, substantia, no, neurotic plaques, but this is Parkinson's, of course. Talking about Alzheimer's with D, so no. This picture is the picture of frontotemporal dementia, Pick's disease. Here we go. Right, someone has a sleep disorder and acting out of dreams involving violent movements. He has a 3 per second tremor of his hands. He has blank facial expressions, slowed mentation, but his memory is intact. Difficulty standing, and when he does, postural hypotension occurs. There's increased resistance to passive movement. So here is a person who has got the symptoms of Parkinsonism and also has got problems with dentition. So he's probably got some kind of problem that is like Parkinson's disease dementia. What is the problem there? It's a problem with alpha-synuclein. So this is the answer is A. This one is, know it, Alzheimer's. Huntington is, of course, Huntington's disease, which we haven't talked about yet. The JC polyomavirus, worth looking up. Good virus to avoid, but we all have it. I think it just becomes reactivated in people, and of course, tau is associated with Alzheimer's disease and Pick's disease. But all these things, we learn a lot from multi choices. All these things are associated with Parkinson's disease, dementia. All right. Next, we're going to talk about vascular dementia and mixed dementia very briefly. So vascular dementia is about 15% of all dementia cases. It's very associated with age, okay? And of course, the usual things that harm vessels. And then, of course, people get mixed dementias. I'm going to correct my slide here. Patients can have Alzheimer's disease and vascular dementia. This is the most common combination where they will, exhibit Alzheimer's symptoms, but also have vascular dementia. I have found this really, really useful diagram here, and this is where you get it from. And if we can zoom in on it, here we go, let's try and zoom in on it. All right, understanding different types of dementia. So here they are compared: Alzheimer's, frontotemporal Lewy body dementia, vascular dementia. It talks about their pathology. It talks about their symptoms. Okay, talks about the age that they get it, and makes general statements about diagnosis and treatment. So I think this is a particularly useful thing that you can download. Okay. So yeah, sleep is associated with Lewy bodies. All right, let's go back to making that fit in the slide again. And we will carry on. Huntington's disease, another brain degenerative disease. Yeah, I know that you did this in ELM as well. Mutations in the Huntington gene. And this is unusual because it is a trinucleotide repeat. So when we do genetics, we're going to talk about this. So there are several diseases that are trinucleotide repeat diseases, okay? Fragile X is another one, where in this case, you get lots of CAG, 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 CAG. And the gene can cope with like up to 28 repeats, but once it gets longer, it kind of supercoils. You know how you're twisting rope and it supercoils? And then the protein cannot be transcribed properly. Okay. Actually, that explanation is wrong. Sorry. Once it's made into a protein, it can't handle all the repeat of that amino acid, and it supercoils, right? And so then it gets cut up into toxic fragments that kill the neurons in the basal ganglia. So here we've got a brain here with normal basal ganglia, and here we've got one with abnormal basal ganglia, right? And that person has Huntington's disease. So we can learn the symptoms from this next MCQ, I think. So here we go. The affected person moves bizarrely at times in a jerky, random, uncontrollable pattern. So hemibolismus, like this, is typical of Huntington's disease. So his parents don't suffer from it, but on his father's side of the family, he does have relatives that suffer from it. So why don't his parents suffer from it? Well, sometimes there's two reasons. Firstly, you can get incomplete penetrance, so people can have the gene but not have the disease. But the second thing is a thing called anticipation. So in genetics, we'll learn about anticipation, and it's where, as the generations progress, you get more and more CAG repeats added to the gene and hence the protein, and thus the disease tends to manifest earlier and more severely. But we know that the part of the brain that's affected in Huntington's disease is the basal ganglia, and in particular, the caudate nucleus. Okay, not the motor cortex, that's here in the parietal region, but the caudate nucleus. Okay, carrying on. Motor neuron disease. So motor neuron disease is another degenerative disease. It's a group of disorders. The most common one is amyotrophic lateral sclerosis, sometimes in America called Lou Gehrig's disease. It is affecting both the upper motor neurons and the lower motor neurons. And it's characterized by weakness. So starting with foot drop, then progressing to leg weakness, people can't walk, and arm weakness, until they are left motionless, unable to speak inside, trapped in their bodies, but their mind and intellect are left intact. It is a devastating disease because it affects people who are often in their late 50s. And death is from respiratory impairment when the diaphragmatic muscles are affected. So let's think about motor neuron disease pathology. About 20% of are familial, so autosomal dominant with incomplete penetrant. But the rest are sporadic. There's an increased risk in people who have been exposed to toxins, but like not a firm association. Again, it is a protein aggregate problem, right? So protein aggregates cause cell injury within the motor neurons, and that causes apoptosis. And it particularly affects the anterior root of the spinal cord, okay? So this side here, it's got this very large pale bit, right? It's too pale here. There should be some more purple neurons up here. This side is less affected, okay? And of course, the motor gyrus in the cortex can also be atrophic. So that's the last kind of degenerative disease that we're going to talk about. So here we go. So this is a typical talk here. History here. So a 46-year-old man has difficulty holding objects. He has decreased motor strength in the distal muscles of his arms. The distal parts of the body are affected first. No other symptoms. Sensory functions are intact, typical of motor neuron disease. His memory and higher cognitive function are intact, again, typical. Over 2 years, it involves all of his arms and legs. He has difficulty speaking and swallowing. So this is typical of motor neuron disease. So the part that's affected is the corticospinal tract. Okay, here, corticospinal tract. All right. So final summary from Robbins. Neurodegenerative diseases are characterized by progressive neuronal loss, mostly associated with aggregates of protein. You need to know which protein belongs to which disease so that you understand the treatment and the phenotype, the symptoms that the patients are expressing. That will help you diagnose the disease. Okay. And they're often grouped right into the dementias, right? The hypokinetic movement disorders like Parkinson's, the hyperkinetic movement disorders like Huntington's disease, cerebellar ataxias, and the motor neuron diseases. Okay, so I did promise you now that I was going to tell you the answers to the MCQs from the previous thing. So I'm just now going to open this again here. And we're going to shoot down to the MCQs at the end. Now that we've had lots of thinking about MCQs, degenerative brain disease MCQs, we're going to hop back to these ones here. All right. So one of the things you have to do with MCQs is make the diagnosis before you look at the answers. You have to make the answer before you look at the list. So let's look at some key information. She is middle-aged and has ischemic heart disease. It's a sudden loss of consciousness. Remember I was telling you about sudden versus gradual? They resuscitate her. Okay. But oh dear, her systolic pressure is only at 48 millimeters, so she's been in shock. Know about brain shock and watershed areas. All right, bilateral wedge-shaped frontal parietal areas, 2 to 3 centimeters lateral to the midline. So, right, so she has got classic lesions of watershed injury. Okay, we looked at it up here. So this is the description. Bilateral wedge-shaped frontoparietal, and somewhere up here, we talked about watershed injury in the very beginning from your previous lectures. And we had a lovely picture, it says, which I now can't find, just looking through the things on there. But yes, so this is a typical watershed injury. Okay. Next one. Right. 67-year-old has been drifting into a coma over 2 hours. He has quadriparesis. He can't move. CT shows pontine hemorrhage, so that will immediately go, oh, Durette hemorrhages. He's got cerebellar tonsil through the foramen magnum. Okay, it's pressing his respiratory center. Okay. From autopsy, the hemorrhagic area examined microscopically shows hyaline arteriolar sclerosis and lacuna infarct of the thalamus. Oh, which of the following conditions is most likely the risk factor? So I got that all wrong when I was reading this, because what I have failed to teach you about is the other cause of pontine hemorrhage. Okay, so there are two areas where there are direct penetrating arteries. One is the thalamus, that gives bleeds into the internal capsule, as we learned before, and the other one is the pons. Okay, so you also get pontine hemorrhage through direct penetrating arteries that develop little aneurysms and then pop there directly. Okay, so this is telling us it's in the pons, all these symptoms. This is telling us he has arteriolar problems, with the hyaline change, because they've got lacuna infarct. And even here, it's hyaline arteriolar sclerosis. So the deep penetrating arteries of the pons are the problem. So he would have had, most likely, chronic hypertension. Okay, because all those changes are associated with hypertensive brain disease. Next. Right, 43, dull headaches and a seizure. Oh, headaches and a seizure. That's thinking about maybe space-occupying lesions. Normal vital signs. He's got mild spasticity in his left arm. So we do have some localizing symptoms here to the right brain. Normal electrolytes. A solid 3 centimeter hyperintense mass with an ill-defined border in the right posterior frontal lobe. It's minimally vascularized on angiography, so it's like not like a brain vessel malformation. All right, so what is it likely to show? What do we actually think it is? It is a solid, bright white mass. Does that remind you of anything? Does that remind you of anything, of any of the CTs that we saw earlier? Solid, bright white mass that is in his brain. Probably maybe a bit like this one. Right. So what that actually is a meningioma. So that bright, hyper-intense radiology is typical of a meningioma. Remember that glioblastomas, metastases, lymphomas, they have the ring enhancement, and astrocytomas tend to be enhancing but diffuse and in the brain parenchyma. So I think that he has got, here we go, world clusters of meningothelial cells, because I think he's got a meningioma. Okay, we did that one. I think I missed this one out. Right, this is a 14-year-old. He's got back pain with fever, difficulty walking, and a temperature, diminished movement sensation, lower extremities, and is incontinent of urine. This is a problem. Sounds like something really bad is happening in her spine. Okay, she's incontinent of urine. And lower extremity. So it's bilateral. So something's happening in her spine bilaterally, maybe in the cauda equina. She's going with her fever. She's got mutes on her white blood count. And she also has a cardiac murmur. So we're kind of putting it together now. She's 14. She's got a murmur, maybe infective endocarditis, which has broken off and metastasized to the lower spinal area, cauda equina area. So what might she have here? So probably she's got an epidural empyema. So she's got like cauda equina syndrome from an abscess, an epidural abscess forming. She's a bit young for disc herniation. It can give rise to, incontinence of urine and bilateral leg weakness, but no fever, osteolytic metastases, 14, not particularly, demyelination, so thinking MS, again, not particularly associated with cardiac murmurs, scoliosis, well, they probably would have noted that. It also explains, the abscess also explains pain there in the thoracic spine. Okay, good. Did that one, done that one, that one. Okay, so we've got a 24-year-old with a seizure. He has an irregular mass of vascular channels in the subcortical region of the right parietal lobe, fed by a branch of the middle cerebral artery and draining into a venous sinus. So this sounds like an abnormal arteriovenous malformation. Okay, so it comes from an artery, it has squiggly enlarged vessels, goes into a vein, arteriovenous malformation. And yes, indeed, it shows enlarged blood vessels separated by gliotic tissue. Yes, with evidence of previous hemorrhage. This is what they do. They tend to bleed on and off. All right, which of the following cerebral lesions is most likely the undercause of these features? So we know that it's an AV malformation. So we can now look down and think of and there it is, malformation. It's not a tumor, right? It's not a glial tumor. And all of these things are just the rest of the red herrings. So we've learned about AV malformations and that they actually exist and they aren't tumors. All right, here we go. 74-year-old woman has blunt head trauma in a motor vehicle accident. She's conscious but disoriented. She has a right temporal bone fracture and mild cerebral edema. So at the moment you're going, oh, epidural hemorrhage, which by the way is the same as extradural hemorrhage. I think they call it extradural in the US. Oh no, she's has been drinking a bit. But all right, so let's look at her 2 days later. She's got a very, very low sodium. Remember, normally not below 130. Potassium's all right. Rest's looking not too bad. These are all American values. So the hyponatremia is corrected over the next 2 hours with IV fluid and electrolyte therapy and diuretics. At this point, you go, big mistake. Okay, so I know that you haven't done sodium chemopath yet, but if you correct people's sodiums too fast, there's a particular syndrome that they get. They get central pontine myelinolysis. Okay, so this is what happens. She then becomes confused, has wind and limb weakness. So she's got central pontine myelinolysis, and you can't come back from that. So it's a warning about chemical pathology and correcting people's sodiums slowly. All right, I believe that takes us to the end of all the CNS stuff. As always, email me if you remain confused. And now it's time to say, hey, call mai. See you later.